Cher comité, merci beaucoup pour l'opportunité de présenter notre étude au sujet de la douleur post-opératoire chez les patients subissant une réparation d'une hernie insurrectionnelle. Je ne parle pas très bien français, donc je vais continuer la présentation en anglais. I have nothing to disclose. Incisional hernia remains one of the most frequent complications after abdominal surgery. The incidence is between 5 to 30%, and incisional hernia is associated with high healthcare costs, discomfort, pain, and an impaired quality of life. To prevent and treat incisional hernias, the abdominal wall can be reinforced using a mesh. However, mesh reinforcement is also associated with chronic pain. Nowadays, also due to the influence of the media, there's an increased resistance for meshes among hernia patients. We wonder if this commotion is justified, or do we actually replace one problem with another? So our primary aim was to investigate the pain reduction in preoperative symptomatic patients and the pain induction in preoperative asymptomatic patients undergoing incisional hernia repair. The secondary objective was to determine the preferred mesh type, the preferred mesh location, and the surgical technique in minimizing postoperative pain and discomfort. To answer these questions, we used the Hernia Club Registry database. All adult patients undergoing incisional hernia repair between September 2011 and May 2019 with a follow-up of 3 to 12 months, which had data on postoperative pain and or discomfort were included. Hernia patients were defined as symptomatic when they had a hernia that causes either pain, sensory complaints, or causes other discomfort problems. First, we split the data set into two groups, the preoperative asymptomatic patients and the preoperative symptomatic patients. And after surgery, we assessed the complaints from patients' surgical site. After this, a univariate and multivariate regression model was used to identify factors which are associated with postoperative chronic pain. In this logistic regression model, multiple imputations were performed to ensure maximized use of the available data, and variables potentially related after univariate analysis and factors of clinical interest were considered for multivariate analysis. A total of 1,312 patients underwent incisional hernia repair and were included, and of these patients, 83% were symptomatic before surgery. Here we see the table with the preoperative hernia characteristics in both groups. Around 25% of patients had a recurrent hernia, and notable is the differences in patients that had previous surgery with mesh. Patients with an intraperitoneal onlay placed mesh had significant more complaints compared to the other mesh locations. Also, patients with a large hernia have significantly more complaints compared to the smaller hernias. In this flow diagram, it shows the pre- and postoperative pain and discomfort. Notable is that 20% of all preoperative asymptomatic patients reported pain or discomfort postoperatively after a median follow-up of 11 months, and around 70% of all preoperative symptomatic patients had no postoperative complaints, so nearly 30% remained symptomatic. This table shows once again the postoperative discomfort after median follow-up of 11 months, but now with the discomfort specified with VAS or an NRS score. Multivariate analysis showed that any preoperative discomfort is associated with postoperative discomfort. Also, mesh fixation with the use of tackers or using a self-adhesive mesh is associated with postoperative pain or discomfort. So in conclusion, in symptomatic incisional hernia patients, hernia-related complaints may be resolved in the majority of cases undergoing surgical repair. However, in asymptomatic incisional hernia patients, pain or discomfort may be induced in a considerable number of patients after surgical repair. Preoperative discomfort is a risk factor for remaining or inducing pain and discomfort. And additionally, mesh fixation using tackers and self-adhesive meshes is associated with chronic postoperative pain. In this cohort, a considerable number of preoperative asymptomatic patients underwent surgical repair. For some patients, the shame of the cosmetic appearance of the ventral hernia is a more prominent reason to undergo hernia repair rather than pain or discomfort complaints. Another reason to repair a ventral hernia is the risk of incarceration. Some studies showed that watchful waiting for incisional hernia is safe. However, one study showed that watchful waiting leads to high crossover rates, with significantly more incidence of intraoperative perforation, fistulas, and mortality for emergency surgery. Then, can we explain the outcomes of this study? The peritoneum is known to be intensively sensitive to pain. This could be the reason why we observed that preoperative patients with already an intraperitoneal onlay mesh had more complaints compared to the other mesh locations. However, this was not seen after multivariate analysis. Also, we found that patients with a large hernia have significant more complaints compared to the smaller hernias, which seems to be very logical. However, the small hernias of 3 to 4 centimeters of size are more at risk for incarceration. Additionally, the traumatic mechanism of tackers and self-adhesive meshes can be a good explanation why these fixation tools are associated with postoperative chronic pain. This cohort study has, however, some limitation. First of all, pain is a relatively subjective measurement. However, to minimize this effect, we assessed multiple aspects of pain and discomfort in this cohort. Although all data was collected prospectively, the results may be influenced by selection bias due to the observational study design. Furthermore, only surgeons specialized in abdominal wall surgery performed the hernia repair. With this in mind, we can assume that this study represents a relatively low rate of complication, and that chronic postoperative pain might be underestimated in this cohort. With this study, we recommend to inform your incisional hernia patient about the risk of postoperative pain, especially when it concerns an asymptomatic patient. Furthermore, we recommend using sutures instead of tackers or self-adhesive meshes to prevent postoperative discomfort. We would like to thank all surgeons and research associates of the Hernia Club, and especially Dr. Guillon for collecting all the data. Thank you very much.